Welcome everybody to today's acid-base lecture series. I'm going to be talking today about unusual acid-base cases. These cases are unusual not only from the clinical point of view and are interesting, but I'm also going to be presenting cases that have complex acid-base disorders to diagnose. So the first case is a 55-year-old woman who had an infected knee prosthesis. As far as her past medical history, she was diabetic and obese, and she was in hospital and treated with Norco for pain relief over a 6-week period, and she had some vomiting. Regarding her lab results, her sodium was slightly elevated. Her total CO2 was significantly decreased and was 10. She had an elevated creatinine of 2.2. Her blood sugar was slightly elevated, and she had a significant elevation in her anion gap of 33. Regarding her blood gases, her pH was 7.44, her PCO2 was 14, and she had a bicarbonate of 9. Before getting into her acid-base diagnosis, I wanted to refresh your memory regarding the differences between male and female acid-base parameters. In males, the average PCO2 is 40, and the bicarbonate is 24. In females, the PCO2 is 38 with a bicarbonate of 23. Now, in our patient, the PCO2 was 14 and the bicarbonate was decreased to 9. In order to make an acid-base diagnosis, we compare the patient's current PCO2 and bicarbonate to either the patient's previous normal numbers if you have them, and if not, you compare them to population norms. So the PCO2, since we don't have previous numbers, we'll assume normal female numbers. So her PCO2 fell by 24, assuming the normal is 38, and the bicarbonate fell by 14, assuming the normal bicarbonate in a female is 23, which gives a ratio of 17 to 10 or 1.7 to 1. Now, in order to make an acid-base diagnosis, we see whether this ratio is what is predicted for one of the 3 acid-base disorders that can cause a drop in the PCO2 and drop in bicarbonate. So if this was a compensated metabolic acidosis, we'd expect the PCO2 to fall 12 for every 10 fall in the bicarbonate. So clearly our patient didn't have this. Could it be acute respiratory alkalosis? Well, the fall in the PCO2 of 10 should have been associated with a fall in the bicarbonate of 2, which clearly, again, is not the case. Nor does the patient have the expected values in chronic respiratory alkalosis, where the PCO2 falling by 10 should be associated with a fall in the bicarbonate of 4. Some people say 5, but in that range. And clearly our patient did not fall into any of these. Now, we do know that the patient had a ratio of 12 to 10, and so it could not be one of these 3 disorders. It has to be, if it is metabolic acidosis, for example, it could not be just a compensated metabolic acidosis. Now, we have a clue that it likely is at minimum a metabolic acidosis because the anion gap was elevated. So the question is, what else would the patient have in addition to an anion gap metabolic acidosis? And since the PCO2 has fallen greater than we would expect from a compensation, an appropriate compensation or predicted compensation, the patient must also have a respiratory alkalosis. In other words, the PCO2 fell further than we would expect. So far, we have a diagnosis of an anion gap metabolic acidosis. We have an elevation of the anion gap with a fall in bicarbonate, and the PCO2 has fallen more than we would expect. So the patient also has a respiratory alkalosis. But is that sufficient? Well, let's back up a little bit and think for a minute what happens when someone has an organic acidosis or organic metabolic acidosis or an elevated anion gap metabolic acidosis. The anion comes into the blood from the cells, but it also comes in with a proton. So the anion flux into the extracellular fluid is matched by an equivalent or an exact amount of protons that come into the extracellular fluid. Also, the anion does not come in as the sodium or potassium salt or the calcium salt. It's always coming in with a proton. Now, the anion elevates the anion gap. The proton is what causes the metabolic acidosis. The anion coming into the extracellular fluid does not cause the metabolic acidosis. It's the proton combining with bicarbonate and lowering it. Now, if we assume that the anion coming into the extracellular fluid is matched by the same amount of protons coming in and lowering the bicarbonate, then you might assume that the increase in the anion gap is equal to the fall in bicarbonate. And this thought is used to calculate the original bicarbonate, where the original bicarbonate is equal to the change in the anion gap, the elevation of the anion gap, plus the current bicarbonate. But the assumption is that the anion load and the proton load go into the same volume of distribution, and that the anions aren't excreted, and that the bicarbonate is not generated by the kidney, and that the anion is not converted into bicarbonate. All these assumptions are not necessarily true. However, if they were true, then it would be true that the change in the anion gap would equal the change in the bicarbonate, and one could look at the change in the anion gap plus the current bicarbonate to calculate the original bicarbonate. So this is what's done clinically, even though those assumptions aren't necessarily true, and on an exam to calculate the original bicarbonate concentration if the metabolic acidosis was not there. So in our particular patient, we have a change in the anion gap of 22, assuming the original level was 11, excuse me. That's a change, a delta anion gap of 22. And if we take that number and add it to the current bicarbonate of 9, we get an answer of 31. Now that answer of 31 is interesting because we would expect that you, in the absence of the metabolic acidosis, you would have gotten an answer of 23, 24, or 25. This suggests that there's another acid-base disorder raising the bicarbonate above its normal level. And the two acid-base disorders that could be doing this are metabolic alkalosis or respiratory acidosis, which we further divide up into acute or chronic. Now, acute respiratory acidosis could not do this if we look at the change of 10 in PCO2 with a change of 1 in the bicarbonate. Chronic respiratory acidosis, possible. For every 10 increase in the PCO2, the bicarbonate goes up 3.3, 3.5. Metabolic alkalosis, yes, it could be. The most likely diagnosis is metabolic alkalosis as a cause of why, in the absence of the metabolic acidosis, the bicarbonate would have been predicted to be 31, because for chronic respiratory acidosis, the PCO2 would be chronically elevated, and we already know clinically in our patient, the ventilation is greater than normal. The patient has a respiratory alkalosis, so there's no problem with ventilation. So the chronic respiratory acidosis would be unlikely. So the most likely diagnosis in our patient is a metabolic alkalosis. So the patient then has 3 acid-base disorders: an anion gap metabolic acidosis, a respiratory alkalosis, and a metabolic alkalosis. So the question is, what happened clinically? Well, the norco was stopped and the acidemia slowly corrected, suggesting that it was somehow related to the norco. Now, if you remember, norco is made of oxycodone and acetaminophen. So is this associated with oxycodone? No, it's associated with the acetaminophen. And what the team did is they realized the association and ordered a pyroglutamate level, which is also called 5-oxyproline, and it came back significantly elevated at 10.5. So the team made a clinical diagnosis of pyroglutamic acidemia. That's the cause of the anion gap metabolic acidosis in this patient. Now, it was back in 1974 that Larson first published a article that described pyroglutamic aciduria, and this was associated with an inborn error of glutathione metabolism. It was published in Pediatric Research. And it turns out that pyroglutamic acidemia is a rare autosomal recessive metabolic disorder, usually appearing in infancy. And it's characterized by developmental disability, ataxia, hemolytic anemia, and a chronic metabolic acidosis. It's caused by a significant deficiency in glutathione synthetase activity. So these patients cannot make glutathione. Glutathione is a critically important antioxidant. It's a linear thiol tripeptide. It's made of 3 amino acids, and it's present at relatively high concentrations in virtually all mammalian cells. It's composed of glutamate, cysteine, and glycine. Another paper was published later on that was the connection with Tylenol. Creer published the first case of an anion gap metabolic acidosis that was due to pyroglutamic acidemia in an adult patient that had nothing to do with any mutation in the enzyme. And they tried to rule out other causes of metabolic acidosis, ketoacidosis, lactic acidosis, all the usual ingestions that we think about, and they were ruled out. But the patient was found to have, as in this original inborn error patient, high concentrations of pyroglutamic. So the thought here was the patient had an acquired form because it wasn't present throughout their life, whereas kids who have this from a genetic mutation have it from birth very early on. And they did a drug screen and it was positive for acetaminophen. And the biochemical abnormalities gradually resolved, giving IV fluid. They gave some bicarbonate for the metabolic acidosis. They stopped the acetaminophen. And this is a clearly complicated slide, but I just wanted to show you some of the key points and why it occurs with acetaminophen. So there's actually 3 enzymes involved to make glutathione finally. You have an enzyme that converts glutamic acid to gamma-glutamyl phosphate, and this then reacts with cysteine to make gamma-glutamyl cysteine, and then you have the gamma-glutamyl cysteine added to glycine to make glutathione. And the problem is that acetaminophen is metabolized into this compound called NAPQI. And NAPQI binds to glutathione and decreases its level. And when that occurs, it sort of stops the whole pathway, and you end up with a vicious cycle in the first enzymatic reaction where glutamic acid is converted to gamma-glutamyl phosphate. But instead of having cysteine then attached, the gamma-glutamyl phosphate is converted into 5-oxyproline, which is the acid that causes the metabolic acidosis. And then this is converted back to glutamic acid, and this keeps utilizing up ATP and just circling around and around and around and around. It's a vicious cycle. So the main reason is NAPQI is created. And also you end up, as I'll show you on the next slide, with a depletion of cysteine in the body. So the second reaction can't occur. So this is the first cycle that occurs due to the NAPQI, where glutamate is converted into this intermediate. This is the organic anion, and then back to glutamate. So you just keep making glutamate and making more of the 5-oxyproline, which causes the metabolic acidosis. Now, the key thing that starts this off is that 5% of the acetaminophen is turned into NAPQI, which decreases the glutathione levels and stimulates that first cycle. 50% of it is excreted in the urine as sulfated metabolites, shown here, including cysteine, which is why you get depletion of cysteine in the body. Decreases the cysteine stores and the formation of gamma-glutamyl cysteine. And the other problem with the NAPQI, which is the main culprit, is it binds it's very reactive, and it binds other molecules, for example, in the liver, causing toxicity, which is one of the reasons you get liver toxicity with acetaminophen. It's the NAPQI metabolite. So the true frequency is unknown. It occurs with a lot of acetaminophen. The dose is not clear. It's felt to also be long-term use and not acute use. So, but it's pharmacology of why some people get this and others don't is not clear. There are rodent models where you can put the acetaminophen in drinking water and you can create the same problem. The majority of patients tend to be women with various chronic medical diseases, and it does stop when you discontinue the Tylenol. Some people give in acetylcysteine. It may accelerate the recovery by increasing the amount of cysteine you have, repleting your cysteine stores. And in a rodent model, methionine also helped prevent development of disorder, and that may be due to its conversion into sulfur-containing amino acids, including cysteine. Occasionally, people have to be dialyzed. You could get this on your board, so it's something, if you have a metabolic acidosis in someone who was on Tylenol that's unexplained, you should immediately think of this and work the patient up for it. It tends to occur also with certain background medical conditions like malnutrition, chronic alcoholics, liver disease, kidney disease, female sex, and long-term acetaminophen use. So there are some background medical chronic issues that tend to predispose to it, but why these and not others is not clear. But these are the type of patients it's been seen in the literature. So again, I'm sure you have many acronyms for trying to memorize all the organic acidoses. This is just one of them called mud piles, which I'm sure you've heard, and it's revised, and there are other ways to remember these. So you can use whichever you feel is best, but basically there's methanol, uremia, diabetic ketoacidosis, pyroglutamic. There's two types of P's, propylene glycol, and then ingestions, lactic acidosis, ethylene and diethylene glycol, and salicylates. And some people like to memorize the acronym GOLDMARK, which has similar but not exactly the same organic acids. Remember that the cause of an organic acidosis is not the organic anion. The organic anion comes from the cells and gets transferred to the extracellular fluid with a proton, not with sodium or potassium. And it's the proton that causes the metabolic acidosis by binding to bicarbonate and other buffers. It's just we tend to think of bicarbonate when we diagnose acid-base disorders, but it'll bind other buffers depending on their pK. So the proton binds to bicarbonate and lowers it. The anion comes in and raises your anion gap. Now, each of these things has different organic anions that you just need to memorize. So ethylene glycol, there's a list of all the organic anions that are felt to be causally related to the metabolic acidosis. Diethylene glycol, there's two organic acids that create the metabolic acidosis. Propylene glycol is lactic acidosis. Methanol, remember, is formic acid. That's felt to be what causes the eye problems. It's the formate. INH is lactic and ketoacidosis, ecstasy lactic, cathinones lactic. Okay, so remember acetaminophen organic metabolic acidosis. This is another patient, a 23-year-old female, G2P1A0, admitted at 32 weeks gestation because of hypokalemia that was resistant to treatment. 2 years ago, she had another pregnancy with labor induced at 37 weeks gestation. She was hypokalemic at that time and hypertensive, but the K was normal after pregnancy. And on physical, she was hypertensive. Now remember, in pregnancy, the blood pressure is normally what you see here. So even though you might think 131/81 is not so bad, it is quite high for a normal pregnant female. And these were the lab results. She was hypokalemic, and she had a high fractional excretion of potassium. Remember, you calculate the fractional excretion of any ion in the urine the same as you do for sodium. It's the urine concentration divided by the blood concentration times the blood creatinine over the urine creatinine times 100. And the fractional excretion of potassium should be 1 or 2%. It should not be 33%. You can do the TTKG also. They tell you the same thing. It tells you that there's a renal tubular cause for the hypokalemia. Other tests that were ordered were the magnesium, which came back normal. The calcium was perhaps a little bit low, but for the third trimester, but was still within the normal range. And the main findings were that the aldosterone, which is normally 4 to 31, was less than 3. And in the third trimester, it's normally 60. And the renin was also low. In the third trimester, it's normally 14. And she remained hypokalemic despite getting potassium chloride and magnesium supplements. And at 37 weeks, she was induced. And these were her labs, her blood gases. So you might look at this and go, oh, there's nothing abnormal. I mean, maybe the bicarb is 25, a little bit high for a female, but the PCO2 looks normal. So you'd say, these look pretty normal to me. But the problem is, in the third trimester, you don't have normal blood gases. So the fact that they're normal means there's something inappropriate going on. And it must mean we have at least 2 acid-base abnormalities, because the normal acid-base parameters in pregnancy is a chronic respiratory alkalosis. So if you look at 12 weeks, 24, and 38 weeks, you can see here the PCO2 is roughly around 30. These are mean values in a large group of women, and the bicarbonate's 20. And this is what you'd expect in a chronic respiratory alkalosis, where the PCO2 fell about twice what the bicarbonate fell, or 0.4, 0.4, 0.5 if you want to look at the ratio. So this would be normal. So you can't have normal lab results without having, and you know that this is what should be the baseline, and you know they must have at least this, which is sort of, we call this normality, even though it is an expected acid-base abnormality. And so our patient should look like this, where chronically the bicarbonate should be falling to a new steady state, usually within the first trimester that occurs, and stays somewhat like that the rest of the pregnancy. But our patient had this, our patient had normality. So the question is, what's going on as far as the acid-base abnormalities? So if we see this, it must be a combination of at least chronic respiratory alkalosis, but something else. So given the findings in the patient with the hypokalemia and the chloride in the urine and potassium are not responding to the KCl, it's a pretty good bet that the patient had not only chronic respiratory alkalosis, which we would expect, but a metabolic alkalosis on top of that, in addition to that. And so we end up paradoxically with normal numbers. And remember, there's a compensation with the metabolic alkalosis. So if you normalize the bicarbonate from the chronic respiratory alkalosis number, you're going to end up with the PCO2 going up to what it should be for a normal bicarbonate, which is what it is. It's 38. So both those numbers will increase in the metabolic alkalosis. And it just happened that the magnitude of each of these, even though they're opposite in direction, was their effect quantitatively was equal. So you end up with normal numbers. So the other findings in our patient are the aldosterone and renin were suppressed. Patient was hypokalemic. We know the patient was getting KCl, and yet the metabolic alkalosis did not go away. So we would call that chloride resistant, even though you could do a urine chloride or you could do a fractional excretion of chloride. You don't need to if you know the patient was on chloride and they still had the metabolic alkalosis. The experiment has been done for you. It's chloride resistant. And the patient was hypertensive. So does anyone know what the syndrome is, what this interesting syndrome is, where you get a hypokalemic chloride resistant metabolic alkalosis only during pregnancy that resolves? Well, the first general diagnosis, which has multiple causes, is that the patient has pseudo-hyperaldosteronism, a low renin, a low aldo, hypertensive. They look like they should have hyperaldosteronism, so we call this pseudo because the renin and aldo are low. But that is a general medical category that has multiple causes. In our particular patient, we want to come up with why the patient had pseudo-hyperaldosteronism only during pregnancy that resolved. So the disease is called, or the syndrome is called Geller syndrome. There are other causes. Our particular patient has Geller syndrome, but there are other causes of pseudo-hyperaldosteronism that we won't talk today. One of them is called apparent mineralocorticoid excess, which is due to 11 beta-hydroxysteroid dehydrogenase type 2 deficiency. We'll talk about that another time. Cushing syndrome also. Crusoe syndrome, which is a abnormality in the cortisol receptor. So cortisol goes up very high. They have a mutation on the cortisol receptor. Glucocorticoid aldosteronism, where you've got a chimeric gene making aldosterone, but the promoter has the ACTH sensitive promoter that should only be in 11-beta hydroxylase. Here it's a chimeric gene that's created so that the gene making aldosterone responds to ACTH. Little syndrome, which are mutations in the epithelial sodium channel in the collecting duct, ENaC, that amiloride inhibits and binds to. And then there's congenital adrenal hyperplasia, where you can have 11 or 21 hydroxylase deficiency. All these syndromes have low renins and low aldos and look like the patients should have a high aldo, and that's why they're called pseudohyperaldosteronism. So in our patient, the likely cause is a syndrome called Geller syndrome, and it was described about 25 years ago by Geller in the best journal in the world, Science. And what they described was an activating mineralocorticoid receptor mutation exacerbated by pregnancy. So what's going on here is there's a problem with the mineralocorticoid receptor shown here on the left. So this is what the receptor looks like at the atomic level, and there's aldosterone shown here in the middle binding to it. And anatomically, it's found in the distal convoluted tubule, the connecting tubule, and the cortical collecting tubule in the nephron. So this part of the nephron here, it's not found throughout the collecting duct. These three tubules here is where the mineralocorticoid receptor is expressed. So when aldosterone binds to the mineralocorticoid receptor, there's downstream events on different transport proteins that are just listed here. You don't have to memorize these, but the ENaC sodium channel is stimulated, the ROMK potassium channel is stimulated, the vacuolar proton pump is, and AE1, the chloride bicarbonate exchanger, is also stimulated. And these things, it's really the topic of a separate lecture, but these together generate the metabolic alkalosis. So in Geller syndrome, it's due to a mutation in the mineralocorticoid receptor. Normally, aldosterone, and which has a 21 hydroxylase group. This is the 21 stands for the carbon atom in the protein. It's hydroxylated. Those are what activate the mineralocorticoid receptor. Progesterone doesn't bind because its 21 carbon atom doesn't have a hydroxyl group. And these patients have a serine 810 to a leucine mutation, which actually doesn't inhibit the receptor. It actually activates it. And you end up with aldosterone when it binds, binding normally. But the receptor actually works without a hormone binding it. Without any hormones around, it works about 25% of maximal activity. So that's one problem. The other issue is progesterone. Progesterone, because of the mutation, activates the receptor by the third trimester. Progesterone, increases throughout pregnancy. And in the third trimester, its concentration goes up about 100-fold. So it's dose related, and it reaches a certain concentration where it can bind to this mutated mineralocorticoid receptor. The other interesting thing is aldactone, which normally binds and blocks the receptor. In these patients, actually activates it. So don't give these patients aldactone to treat what's going on, or you'll make things worse. In males, they can also have some activity with some hypokalemia because of the constitutive activation in the absence of aldosterone. Plus, males have not progesterone, but 17-hydroxyprogesterone, and that can also activate the receptor. So interesting case. Remember, metabolic alkalosis that occurs during pregnancy and is transient. So here's another case, a 66-year-old male, diabetic, obese, who had new onset edema and fatigue with chronic hypertension, diabetes, and hypothyroidism, significant hypokalemia, elevated BUN and creatinine, elevated blood sugar, slightly low albumin. And here are the blood gases. PCO2 elevated, bicarbonate elevated, chloride excretion normal. So if you're thinking metabolic alkalosis, you know right away it's not going to be chloride sensitive. So when you have a normal chloride excretion rate, if it is metabolic alkalosis, it's going to be chloride resistant. K excretion was 92. So if you did a TTKG or the fractional excretion, you're going to find that the cause of the hypokalemia was at least in part kidney. Don't know for sure. And there was a lot of protein in the urine. So what is the diagnosis? Well, the acid-base diagnosis, we do the same sort of thing. We look at the delta PCO2 to delta bicarbonate. And in this case, the PCO2 change increased by 11 and the bicarbonate increased by 25. So we get a ratio of 0.44. So let's look at all the acid-base abnormalities that raise your PCO2 and raise your bicarbonate and see what the ratios are. So we again, we have 3. It's always 3 and 3. In metabolic alkalosis, the PCO2 goes up 7 for every 10 increase in the bicarbonate. And in acute respiratory alkalosis, it's a change of 10 to 1. And in chronic respiratory acidosis, it's a change of 10 to 3.3. The first one should actually be flipped because we're taking the PCO2 first in this particular depiction. So the PCO2 would go up by 7 for every 10 increase in the bicarbonate. So what's the diagnosis? Well, if the patient has a metabolic alkalosis chloride resistant, and again, you can say that not because it's one of the 3, but because the patient's hypokalemic with an elevated bicarbonate. You don't get that in acute respiratory acidosis or chronic respiratory acidosis. So it's likely a metabolic alkalosis clinically. And chloride resistant because we know the urine chloride was normal. But the PCO2 has gone up more than or gone up less than we would predict. So you have to have a respiratory acid-base disorder in addition. Okay, so now what they did is they measured other analytes, and you can see here that the renin was low, the aldo was sort of in the middle of a range that you'd expect, but the cortisol level was very high. And the patient also had an enlarged liver with multiple nodules. They did a biopsy of the liver, and they found the histology of these neoplastic-looking small cells. And on immunohistochemistry, they did further tests and showed that these cells were neuroendocrine in origin based on their positivity for chromogranin A and synaptophysin. And there was also some cytokeratins there. So it looked like a neuroendocrine type of tumor in the liver. And the patient was felt to have metastases to the liver. This was felt to be lung CA undifferentiated neuroendocrine. 20 to 50% of these cases are small cell carcinoma. It was first described a long time ago in 1961. And then what they did was they measured the ACTH level, thinking maybe the tumor was secreting ACTH, and it was extremely high. So a diagnosis of ectopic ACTH syndrome was made. And the patient was treated with chemo, ketoconazole, and then dexamethasone when the elevated cortisol level decreased. Remember that ketoconazole inhibits 11-beta-hydroxylase, one of the enzymes that's important in cortisol production, and also 1720 lyase. It's in the biochemical pathway in the adrenal. And so what's going on here is, remember, cortisol can also stimulate. So we talked about Geller syndrome, where progesterone can stimulate the mutated mineralocorticoid receptor, but cortisol can stimulate the normal mineralocorticoid receptor. But however, the reason you don't get this clinically occurring is we have an enzyme in the kidney called 11-beta-hydroxysteroid dehydrogenase type 2, which converts cortisol to cortisone. And cortisone is much, much less active as far as its ability to bind to the mineralocorticoid receptor. But if this isn't occurring, or if you have so much cortisol being made, the enzyme can't keep up. And that's what occurs in Cushing syndrome or ectopic ACTH production. They get a metabolic alkalosis because the enzyme that converts cortisol to cortisone can't keep up with the amount of cortisol that the mineralocorticoid receptor in the renal tubule is seeing. And normally the ratio of cortisol to cortisone is about 0.3 to 0.5 because of this conversion to cortisone. In licorice, you get hypokalemic metabolic alkalosis because you block this enzyme, and again you get too much cortisol. And in AME, this enzyme, apparent mineralocorticoid excess, this enzyme is mutated, and that's why you get the metabolic alkalosis. And the proteinuria, it's a phenomenon that occurs in Cushing syndrome and ectopic ACTH syndrome. Anyway, for any time you have a high cortisol level, you get hyperfiltration. And this patient had proteinuria, which resolved after treatment. There was nothing intrinsically wrong with the glomerulus. And this is what occurs. Normally, if you look at the orange is the 11-beta hydroxysteroid dehydrogenase type 2, which is normally in the kidney. It's also in other organs, and it converts cortisol to cortisone, which is why in the normal kidney, you don't get cortisol activating the mineralocorticoid receptor. You just usually you get aldosterone doing it. But if you're on licorice and this enzyme is blocked, or you have a congenital mutation such as an apparent mineralocorticoid excess, you can't convert the cortisol, and you will end up with effects of cortisol on the mineralocorticoid receptor. Or if you have Cushing syndrome or a lot of ACTH floating around, and even though this enzyme is working, you have just a ton of cortisol there, you'll end up with a dose response effect where the cortisol activates the mineralocorticoid receptor. It turns out there's another enzyme called 11-beta hydroxysteroid dehydrogenase type 1 that does the opposite in other tissues. And you prevent cortisol, or you create cortisol in the other tissues. Okay, here's another patient. You see the clinical background here. And the patient was hypotensive, had hyponatremia, again hypokalemia, and elevated BUN and creatinine, and had a PCO2 of 52 and a bicarbonate of 37. In this particular case, the urine chloride was low, and you can see the rest of the chemistry in the urine there. So when we calculate the change in PCO2 to change in bicarbonate, they were equal. So now we'll go again through the acid-base disorders with an elevated bicarbonate, and you can see here the choices. Again, metabolic alkalosis, the PCO2 goes up for every 10 increase in the bicarbonate. That's the so-called compensatory response, just like in metabolic acidosis, we have the compensatory response. And then the expected changes in acute and chronic respiratory acidosis, the remaining two reasons for an elevated bicarbonate. You'd expect the PCO2 to go up 10 for every 1 increase in the bicarbonate if it's acute, and 10 to 3.3 if it's more chronic. So in our case, we had a change of 1, which means we have a mixed disorder. It doesn't fit any of them. And because we had hypokalemia and a low urine chloride, it's a pretty good guess the patient at a minimum had a metabolic alkalosis, but the PCO2 went up too much, so the patient also has a respiratory acidosis. So again, a mixed acid-base disorder. And the patient had a colonoscopy, and they found a mass in the rectum. Does anyone want to take a guess at what mass you could find in the rectum that creates a metabolic alkalosis? Okay, so a villous adenoma was found, and it was first described in the 1950s. It was called carcinoma of the colon. After the mass was removed, everything subsided. So clearly it was due to the tumor. Now, you need to realize that medically, most villous adenomas cause a non-GAP or hyperchloremic metabolic acidosis with large volumes of bicarbonate-rich fluid and potassium. However, in 10 to 20% of the cases, the tumors secrete a lot of chloride rather than bicarbonate, and you end up with a chloride-sensitive metabolic alkalosis. So the urine chloride is very low, and when you give them chloride, if you can keep up with the loss from the intestine. You can correct the metabolic alkalosis, but obviously the definitive thing to do is just to remove the tumor. So a villous adenoma causing a metabolic alkalosis is on the list of chloride sensitive metabolic alkalosis. Don't forget that. And there are transporters in the stomach and the large intestine that lead to the generation of they're affected that lead to the generation of the metabolic alkalosis. Usually we're thinking of the stomach with a vomiter where we have the potassium hydrogen exchanger on the luminal side. And this occurs also after the so-called alkaline tide where a proton is secreted in exchange for potassium. But remember, the proton came from carbonic acid. So every time a proton is secreted, you generate one bicarbonate ion, which then leaves the cell on an anion exchanger called AE2 in exchange for chloride, and that bicarbonate goes into the gastric vein. So this is occurring excessively when you eat or when you vomit. That's the source of the bicarbonate. It's the gastric vein. Every proton that goes into the gastric lumen generates a bicarbonate that leaves on the basolateral side of the parietal cells into the gastric vein. In the villous adenoma, you have these different proteins here. People haven't really worked out what's going on. Normally, you have this protein called DRA, which absorbs one chloride ion in exchange for bicarbonate. Maybe DRA is shut off, so you have less chloride absorbed and less bicarbonate secreted. You also have NHE3. Remember, that's the apical anion exchanger in the proximal tubule. That's what SGLT2 inhibitors and some other drugs inhibit. Maybe that's what's going on here. There's some effect here, and you have chloride transport being affected indirectly. It's really not clear what's going on in the villous adenoma, other than you get a lot of chloride-rich fluid coming out in the lumen and very low in bicarbonate. Okay, here's another patient. You can see the data here: abdominal pain, vomiting, mild increase in temperature, loin tenderness, again hypotensive without edema, dysnatremia, creatinine markedly elevated, anion gap elevated, leukocytosis, and here's the acid base. Bicarbonate was 8 and a PCO2 of 19. So what's going on here? Well, when we do the delta-delta to get the acid base diagnosis, the PCO2 changed by 19 and the bicarbonate changed by 15, which is 1.3, which is right away you should recognize as close to the 1.2 that you would expect in a compensated metabolic acidosis. So again, we go through the 3 acid-base disorders that give us a drop in bicarbonate and a drop in PCO2. And there's metabolic acidosis compensated, acute respiratory alkalosis, and chronic respiratory alkalosis. So you can see here that the compensated metabolic acidosis is close to our patient. And you might say, well, is 1.3 close enough? And the answer is yes. And we talked about a little while ago what range you would expect before you say it must be something else. But 1.3 is certainly close enough to 1.2. If you did a large population of patients with metabolic acidosis who compensated, a large number of them would have 1.3, but the average is 1.2. So compensated metabolic acidosis, the anion gap was elevated. So we have at least that. But again, we don't stop there. Remember, we add the change in anion gap to the current bicarbonate, and the change, assuming it's 11, the change in the anion gap is 8. So it's 8 above normality, and we now add that to the current bicarbonate to get what the bicarbonate would have been in the absence of the metabolic acidosis. So to get the original bicarbonate, we take the 8, which is the change in the anion gap, and assume that's how much our bicarbonate changed. So we add that to the current bicarbonate to get the original, we end up with 16. And that's very interesting because we don't end up with 23 or 24. So if you see this, it means that the anion gap metabolic acidosis cannot account for the entire drop in bicarbonate. And again, we're making many assumptions. We're assuming, like I said before, that the proton and the anion had the same volume of distribution. We assume that the anions are not being excreted in the urine. And we assume that there's no excessive generation of bicarbonate in the kidney that would make these two not equal. And again, in the real world, we don't have such perfection, but on an exam and when you're discussing the case with your attending, it's worth going through this mental exercise. And when you add the change in the anion gap to the current bicarbonate, it's interesting that you don't get 23 or 24. So the simple thought is that you must have another acid-base disorder dropping the bicarbonate. So the full acid-base diagnosis for an exam would be that you have a compensated anion gap metabolic acidosis. That's what we said on the previous slide, but that cannot account for the drop in bicarbonate, or you would have ended up when you added the delta anion gap to the current bicarbonate, you would have ended up at 24 or 25, something like that, not 16, which means you also have a non-anion gap pattern. And if there's diarrhea or something else, you have a non-anion gap metabolic acidosis in addition. I say the word pattern just because you can see this kind of thing if anions were excreted in the urine. So you can see this in ketoacidosis once you volume replete the patients, the anions, and get rid of the pre-renal failure. The anions can come out in the urine. The bicarbonate, though, can still stay low if you didn't give insulin. You can get this discrepancy. But so that would be the most common reason why it doesn't add up to 24, 25. But assuming that wasn't the case and there weren't anions in the urine, and you had another cause, a non-gap cause of metabolic acidosis like RTA or diarrhea or ureteroileostomy, you have two types of metabolic. This would be an exam question where you have two types of metabolic acidosis, and you only know it by adding your delta anion gap to the current bicarbonate. So the question is, what was going on? And the patient, this patient was treated with antibiotics. CT of the abdomen was normal, but 5 days later, the patient required dialysis, labile hypertension, neurologic symptoms started, bilateral facial nerve palsy, bulbar symptoms requiring ventilation, MRI. So a lot of neurologic abnormalities going on here. Brain edema, herniation. The patient unfortunately died. Does anyone know what might be going on here, where you get GI, renal, and neurologic symptoms that are acquired? It suggests some sort of toxin. And this is what you get in diethylene glycol. This is a perfect case. It can't be anything else. This is what you see in someone who ingested diethylene glycol. And the patient's friend said she drank 150 mils of clear liquid and it was containing diethylene glycol. It's a common industrial solvent. It has a very sweet taste, and it's used to dissolve compounds instead of alcohol. And you always get these three phases: GI initially, then renal, then CNS. And the reason for the organic acidosis is you get 2-hydroxyethoxyacetic acid made with glycolic acid. So there's two organic anions that each come into the blood with a proton. That's why you get the elevated anion gap and the metabolic acidosis. And these compounds, these organic anions, are thought to be the cause of the toxicity in the kidney and the brain. And it's interesting because it's linked to this incident that occurred in 1937 that was actually written up in JAMA in 38, where it was called Messingill's elixir, the sulfanilamide incident, where 100 people actually died, and it led to the passing of the Federal Food, Drug, and Cosmetic Act. This was one of the main motivators of this act. So sulfanilamide used to be used to treat strep infections, and it was shown to be safe for some time in tablet and powder form. But in 1937, the SC Messingill Company in Tennessee reported a demand in southern states in the U.S. in a liquid form. So at that time, this chemist, whose name was Harold Watkins, found that it could be very nicely dissolved in diethylene glycol. And so they created this elixir, what they called a liquid, that had dissolved the sulfanilamide. It had a nice sweet flavor and fragrance. They sent 633 of these throughout the country, and 100 people died. Many developed acute kidney injury from it too, and it was all because of the solvent, the diethylene glycol. So a very famous incident, and it's something you could get on a test. And I think because of the time, we'll stop there, and we'll continue with a number of other interesting cases with both clinically and with interesting acid-base abnormalities in the next talk. So does anyone have any questions about any of these cases? And again, these are the kind of cases you could get on your boards. So try to go through each of them just so they'll be automatic for you. Not that you're going to see these. I mean, you'll be lucky if you see one or two of these in the first, during your fellowship or in the first 5-10 years after you graduate. But for just for intellectual knowledge and also for the exam, they're worth knowing. Once you've memorized it, you won't forget it. They're very unique. You will see the villous adenoma on causes differential diagnosis of chloride sensitive metabolic alkaloses, and they're unusual because normally when you have diarrhea, you end up with a non-gap metabolic alkalosis or metabolic acidosis, excuse me. It's interesting though that colonic problems of diarrhea tend to cause more often than not a metabolic alkalosis, whereas small bowel, jejunal or ileal causes of diarrhea cause a non-gap metabolic acidosis. So if you have a patient with diarrhea and they have a metabolic alkalosis, it's usually colonic, even if it's not a villous adenoma. And if you have a diarrhea patient with a non-gap acidosis, it's usually anatomically small intestine. So that's just something, it's a little pearl to remember on the ward, that the acid-base abnormality can help distinguish anatomically where the diarrhea is coming from. Okay, everyone, I think if there are no questions, we'll stop there. And thank you for joining and have a great rest of the day.